Campbell, and they'll be speaking about the assessment and revision of a diagnostic paediatric audiology report.
All right, good morning everyone. It's a real pleasure for myself and Rebecca to be here today. And I just wanted to start things off with a wee hypothetical situation. I want you to imagine that your wee 2-month-old boy Johnny has just been diagnosed with a hearing loss. You're feeling pretty shocked, distressed and confused about this because you don't know anyone else who has a hearing loss. Furthermore, you're also feeling pretty overwhelmed with all the information and opinions that various health professionals have given you, the quick pressure to make decisions, and of course those endless questions from concerned family and friends who also want to know what's going on. And so, a few weeks after the diagnosis, you head out to the letterbox and you find a letter from the hospital and you think, could this be it? Is this my golden ticket? Is this the reliable, relevant, easy to read information that I've been looking for? And then you read type A tympanograms, distortion product otoacoustic emissions, auditory brainstem response, severely elevated thresholds and sensory neural hearing loss. And you think, wow, what good is that gobbledygook for anyone? But imagine if the reports that we provide parents could be easy to read, informative, helpful, and relevant for them. Imagine if they could serve to support and reinforce our verbal counselling, and imagine if parents could use them as a tool to show to other family and friends what is going on. Imagine. So I decided to look into this issue a bit further, and here are the top 10 reasons why. Number 1. We're in an international health literacy crisis. Basically, we live in an era that expects us to take ownership of our health outcomes and participate in shared decision making, and we're absolutely bombarded with resources that are designed to help us achieve this. Unfortunately, however, most of us just don't have the skills needed to sift through and then digest all of that information. In fact, 56.2% of New Zealanders have insufficient health literacy skills to meet the everyday demands of the healthcare system. And this is so important because we know that health literacy is linked with poor health outcomes. In fact, health literacy has been shown to be a stronger predictor of health status than age, ethnicity, or socio-economic status. So it's really critical that we're working to improve it. It's also important to understand that health literacy is an invisible problem. It can't be predicted by parents or by education level. It also varies with context and with personal factors such as prior experience and stress. So really, we need to be ensuring that everything we provide parents is easy to understand. And so we can't expect that a beautifully presented lawyer is going to have any better understanding of the statement, ipsilateral acoustic reflexes were absent to broadband stimuli at 90 dB, than Joe Blogg's farmer. Neither of them have the context for that information. So obviously improving health literacy is important, and not just to try and because of the association with health outcomes, but also because of the high prevalence. And international research suggests that the onus for improving health literacy should not just be on the patients, but actually on the health systems themselves. So if we can try and reduce the demands we place on patients by providing easy to read materials, then possibly we can improve health literacy. So in general, it's recommended that materials should be written at the US 6th reading grade level or below. So that's equivalent to New Zealand Year 7, or for those of you who go back a bit further, Form 1, okay? Unfortunately, however, the majority of research has found across a huge number of health disciplines, including audiology, that materials are typically written at the 10th reading grade level or above. And the letters that we copy to patients are often written at the 14th reading grade level or above. So we really need to be thinking about this, and as you can imagine, there's sort of good indication that perhaps the reports we write might be complicated too. And so this is important, not just to improve health literacy, but also because we know we need to support these families of children with hearing impairment. We know that the repercussions of child hearing impairment are really significant for children, but recently research has been emphasising that child hearing impairment creates significant stress and tension on relationships within the family too. And so this is even more significant these days with the move from parent-initiated diagnoses to institution-initiated diagnoses with newborn hearing screening. So we really do need to be providing parents with information that they can understand to meet their need for emotional support and knowledge during those first few weeks. In addition, we know that parental involvement is critical to achieving positive outcomes. So a seminal study by Dr. Moller in 2000 actually found that parental involvement could account for significantly more variance in child language outcomes than any of the other factors investigated, including the age at which children were enrolled in intervention. So, just like Dr. Moller was saying yesterday, we need to be encouraging that confidence and competence in parents so that they can be involved in efficient and effective rehabilitation. Even the coordinators of newborn hearing screening in New Zealand recognise the importance of this family-centred approach, and they explain that the communication of results should be family-centred in a sensitive and culturally appropriate manner. And in addition, it's actually a human right of parents to be fully informed, and they have the right to effective communication as well, in a form, language and manner that enables them to understand the information provided. So really, it's actually our legal obligation and our moral obligation to be providing easy-to-read information. Now, of course, I do recognise that our counselling about hearing loss doesn't start and stop with these written reports. I mean, we obviously provide a lot of clear, concise and comprehensive verbal counselling too, right? Well, maybe. Previous research has actually found that the counselling from audiologists is often perceived as rapid, complex, overwhelming and filled with jargon. In fact, a recent study that recorded paediatric feedback sessions with audiologists found that even though the audiologists tried to simplify and repeat information, and they felt confident that parents did understand the information, the comprehension of parents sort of suggested otherwise. While most of them could remember the overall diagnosis, they frequently could not remember the specific test results, the treatment recommendations, and they had virtually no clue what that graph with all the crosses and noughts was all about. In addition, the information that was remembered was frequently inaccurate. And this is consistent with what we know, that previous studies have shown to us that up to 50% of the information that is told in a verbal consultation is forgotten. And of the 50% that is remembered, a further half is remembered inaccurately. So it's absolutely critical that we are providing parents with this information to help supplement and reinforce our verbal counselling. And I think that reports are really valuable in this resource because, firstly, we're already providing them, so it's just a matter of maybe making them better. And of course, they're also unique. They're personalised for each child, and we know that patients prefer personalised information, and not only do they prefer it, it actually aids in their accurate recall of information and positive behavioural modification too. I also see reports as something that parents can refer to at any time. So I'm not saying that you and the advisors aren't fantastic at your job, but we can't expect parents to call us up at 2:30 in the morning when they've forgotten exactly what we said. The reports can also serve as a resource that parents can use to explain to family and friends, this is what's going on with my child, and this is what we plan on doing about it. So, that was why I wanted to do it, and here's how I set about actually investigating this issue. We divided the study into 3 stages. Firstly, in the evaluation stage, I asked the question, is it true? Are these reports unreadable for parents? In stage 2, we then said, well, what can we do about it? And in stage 3, I asked, well, does improving the reports actually offer any benefits for parents? So, the evaluation stage. Basically, in this stage, I prepared a mock paediatric report based on a hypothetical child's hearing loss, and that was just based on the most common characteristics of child hearing impairment in New Zealand. I then conducted a readability analysis on the report using 4 of the most common formula, and I then sent a copy of the report to each of my parent participants. Now, I want to note here that 2 of the inclusion criteria included that, firstly, parents had to have a child aged 0 to 5 years themselves, so that most common bracket where diagnosis happens in New Zealand, and secondly, that they had no prior experience with audiology or hearing loss. So this was just to try and replicate the fact that 90 to 95% of children with hearing impairment are born to parents with normal hearing who don't have that prior experience. After we sent the report to parents, I then interviewed them following a semi-structured schedule. So that basically assessed their opinions of the report, a few comprehension questions, and also their suggestions for how the report could possibly be improved. I recruited participants until saturation was reached in the data, so basically until 2 consecutive interviews did not produce any new themes. So, what did we find? Well, as predicted, the readability of the mock report failed to meet that recommended 6th reading grade level. In fact, the readability of the report ranged between the 15th to 17th reading grade level. So on average, that's written at the level of a 4th year university student, slightly above the recommended level. Would you agree? The results of my thematic analysis from the interview data produced 7 key themes. So firstly, all parents mentioned the fact that they found the report confusing and difficult to read. They made comments such as, I could hardly even read it to tell you the truth, and the test results, I couldn't understand at all. They explained that the main reason for this was because of that excessive and repetitive use of audiology jargon. So they made comments like, just like gobbledygook. It was saying things about normal, in the normal range, but I have no idea what ranges are supposed to be. And when you get 3 or more words you don't understand in a sentence, well, it's just sort of like, what's the point in trying to understand? Parents explained that because of these reasons, they felt the report's useful value was actually quite limited. It would be valuable to have, but not in the sense that I could just use it to look up as a reference quickly. They also explained that they felt the report didn't mean much by itself. So my conclusion would be that I would need to call up somebody to find out what is going on. The length was also mentioned. It's just that you're not getting much information for that length. And finally, the failure to meet expectations was also quite a common theme that parents mentioned. So one parent made the comment, I'm an engineer. I thought that I would do pretty well reading it, but actually, I felt like I'd failed an exam. So like I said before, the resources that we provide parents, the written ones, need to try and help supplement our verbal counselling to improve that comprehension. Unfortunately, however, it seems the reports by themselves are doing very little for that. So of all the participants I interviewed, only 2 were able to state that the child who had a moderately severe degree of hearing loss had a hearing loss of any degree, that they had a hearing loss at all. And so parents made comments such as, and so they were saying normal. I was thinking it was all fine, until the very end when I thought, maybe it's not normal. Furthermore, only one parent could suggest that some form of rehabilitation might be necessary, and this just kind of highlighted their poor comprehension again. So, I don't know much about it. Maybe grommets? So obviously, if these were the only things we were providing parents, hearing aids are going to come as quite a nasty shock. So, based on the readability analysis and the results of the interview data, I decided it was time for the extreme makeover. So to do this, I used 3 tools. I used a number of guidelines from the literature, the suggestions made from parents, and also some advice from 2 fantastic paediatric audiologists. So I did a huge number of things. I don't really have time to go into exactly what I did, but basically I tried to improve the readability without compromising the clarity or the veracity of the report. So it's just a really quick overview. I did things like including a summary of the results earlier in the report, just to really emphasise that main finding. I did things like using terminology that we actually use in the appointment, so that age-old mountain for a type A tympanogram. I included a diagram of the ear, and I colour-coded this so that the different test results match different parts of the ear. So for example, tympanometry here is in red to highlight the fact that we're assessing the middle ear. I gave a brief overview of what each test was actually designed to assess, and of course I used common terms like loudness and pitch rather than their sort of jargon equivalents. I also gave context to the results by using common sound examples, and I used bullet and numbering systems to help try and distinguish each of the different tests and their outcomes. I developed my own version of the sort of a typical explanatory audiogram, and upon parental suggestion, I included 3 website references and a glossary. So yeah, just a quick overview of what I did, and I'm more than happy to go into more intimate detail because there was a fair bit. But of course it was time to see whether these improvements actually helped. So firstly, we conducted another readability analysis on the revised report, and I then recruited 32 participants who I randomly assigned to read either the unrevised or the revised version of the report. I then assessed a variety of outcome measures, the first of which was their comprehension, and the first of this was through a measure known as a closed test. Now this is essentially a fill-in-the-gaps type measure. So if parents are reading at the correct level of a text, they should be able to correctly fill in the gaps to provide closure to that information. After they'd completed their closed test, I then sent each respective participant their report, and they then filled out a questionnaire that had 6 multi-choice questions, 4 self-efficacy Likert rating style questions, and 8 perception rating style questions as well. So, results from stage 3. Well, when measured by one of the formula, the readability of the report did come in at under that recommended level. Woohoo! When averaged across the 4 formula, it was slightly above the recommended level, but you can see in comparison to the unrevised report, we're doing a lot better. We're getting down to where we need to be for the majority of people in New Zealand. I also found an overall statistically and clinically significant effect of the report allocation on all the assessed outcome variables. And our follow-up analyses again revealed really strong statistically and clinically significant differences between the groups. So on this graph, a higher score up there indicates a more positive outcome, and you can see that the blue report is doing better than the unrevised report in orange across all of the measures. It's also important to understand that I conducted a covariate analysis of variance where we controlled for education level as a potential confounding variable. And even when education level was controlled for, we still found these really massive differences between the groups. So just highlighting the fact that parents of all abilities can benefit from materials that are easier to read. So, I do want to put a few disclaimers out there. This was just my wee master's thesis in 1 year, so it's not perfect. It was just based on one report. And of course, the report that we write for Johnny is always going to be different to that which we write for Timmy, and the report that Barry writes will always be different to that Gary writes. So it is, just sort of an overall base picture. The results of this also highlighted a hearing loss diagnosis from newborn hearing screening. So whether or not these results also apply to VRA and play assessments or normal hearing outcomes kind of remains to be investigated. Of course, we also only had 5 participants in stage 1. While that allowed us to meet the saturation requirements of the study, it's unlikely that the opinions of every New Zealand parent were encompassed in that data. And of course we did recruit those naive participants. So we did this because we didn't want to encroach on parents during that sensitive period following diagnosis, because it was just an exploratory study. And the risk of sort of recall bias prevented us going back and asking parents, how did you find that report that you got 4 years ago? But now that we've got these encouraging results, there's certainly good reason to do a pilot study in real life with the addition of other resources that they're provided too. Finally, the novel questionnaire, while it was really helpful in that it allowed us to assess some outcome variables that are often overlooked, we didn't have time to validate it sort of through and through. So we do need to consider those results with a wee grain of salt. But certainly some good overall findings, and I suppose the wider implications for this have the potential to be quite significant. So the revised report that had improved readability could help to support health literacy of parents. The fact that parents had greater comprehension could mean that they had that greater understanding, which may mean that there's greater attendance to follow-up appointments, greater adherence to treatment recommendations, and overall participation in effective and efficient rehabilitation. And similarly, the fact that parents felt more able to use that information may again contribute to their involvement and participation. And as Dr. Moller has been explaining to us, this is just so critical for outcomes. Finally, the fact that they had more positive perceptions of the report may help facilitate those more trusting relationships between parents and audiologists. We want them to think of us as someone they can go to with all of their questions, no matter how silly they may think they are. So, overall, some really good findings, I think, but I suppose, these conclusions are very much inferential at this stage. We don't know if they are actually going to happen. We've started on the pathway to investigating them, and I suppose the take-home message, though, is that if we change nothing, nothing will change. So it's sort of impossible to know if these great things could happen if we keep doing the same. I don't have all the answers for how we can go about doing this, but my top 5 suggestions just to take home as a starting point today are: look at your own reports. It's really easy to actually just run a quick readability analysis in Microsoft Word and see if you get similar results to mine. Also, chat to your clients. Find out if they do find them acceptable and suitable, or if actually they're just not meeting their needs in the way that they want. Talk to other health professionals. Previous research has actually found that GPs and other professionals also prefer concise and simplified information too. So maybe we can think about stopping writing these massive reports when apparently the health professionals only read the summary paragraph anyway, and we could start investing a bit more time into resources for maybe the people who need it more. And related to this is the idea of efficiency. I'm not trying to, stand up here as some sort of sadistic workaholic, trying to increase your workload by double. I think it's more about working smarter rather than harder. And so there's a number of computer software programs out there that allow reports to be tailored just by simple drop-down menus using basic templates. And maybe that's something we need to kind of consider and look into a bit more too. Finally, feel free to talk to Rebecca or myself for more information, or any other professionals in sort of that health literacy field. I suppose my 2 final questions that I just want to finish with today. Firstly, if you were Johnny's parent and your wee boy had just been diagnosed with a hearing loss, what kind of information would you be looking for in the early stages following diagnosis? And secondly, as a health professional who has dedicated their entire career to improving communication for others, do you think maybe it's about time that we looked at improving our own communication? Thank you.
Hi, Ashleigh. Well done. Fantastic. I'd just like to share that at Hutch Hospital, Allied Health has recently had in-service training about the plain English movement, and I believe there is soon to be sort of changes to legislation that any information that is going to parents, so whatever handouts or reports or anything like that, is kind of what you've done your study on it. It needs to be plain English.
Yeah, absolutely. That sounds really good.
Ashleigh, excellent work. Beautiful.
Thank you.
I just commend your presentation skills as well. Fantastic. I mean, it's definitely a food for thought. I mean, we, as I've shared with the public, DHB audiologists have sent a number of our handouts to the patients, to the qualities, and none of them have been taken as it is, because they have reviewed the whole thing completely, and there is a kind of a quality control for everything which goes out to the patients. And now we would seriously look at the patients' reports as well. Again, a great work. Good job.
Thank you.